It's my pleasure to invite Maxim Didenko, who is now in Bad Enkhuizen in Germany, and he will show you some anatomy on specimens for electrophysiology, especially for complex ablations like Summit and other places. So, please.
Good morning, everybody, and thank you very much for Josef Kautzner. This is a great privilege for me to have a talk. This really great meeting. I realized that I was first time at this meeting exactly 20 years ago, the first time, and then in 2009 I delivered lecture already. So I'm an electrophysiologist, so I'm not really an anatomist, unfortunately, maybe. So, but my field of my scientific and educational interest is anatomy. And when I started to interesting in this field, I must say that my life in my in a P lab become much more simpler. So, and I will try to share this knowledge and to show what we can see with all these specimens. This is plastinated human heart specimens. So it's a human heart, but filled with a silicone. And I would like just briefly, 30 seconds, to remind you that unfortunately all our nomenclature are made from Valentine position of the heart. But we have a left-sided, this is an endocast, so this is the left atrium, left ventricle, right atrium. But what we know that all our structures originated or located in the thorax in another way. So we can see this is an anterior ventricle actually. If we, in terms of localization, this is posterior, this is anterior atrium and the posterior atrium. And when we can see it also with this nice cut for the whole body, we can see this is a right ventricle, which is anterior, left, which is more or less posterior, right atrium, and the left atrium. So when we are talking about anatomy, we always have to understand that how we call them, they are a little bit different in terms of location. And I will go through procedures, not from anatomical point of view, but through our procedures, and probably start with them. One of the most conventional procedure, atrial flutter. So this is again specimen, plastinated specimen, the lateral wall of the right atrium and right ventricle I remove. Already here what we can see, this is a trabeculated part of the right atrium. And as you just saw, we cannot see this kind of morphology in during our mapping. And this is, in my view, extremely important because we also know that the propagation goes along these fibers. And this is also can be important to understand how the propagation goes through these fibers. And we can see it, for example, with the transillumination, how the complex and how non-homogeneous the wall of the right atrium. Right atrium is actually has a three parts, anatomical parts: the venous part, trabecular part, and vestibule, close to tricuspid valve. We also know that they have a different embryological origin. So the venous part is originated from sinus venarum, and trabecular part with the right atrial appendage from primitive right atrium. And the crista terminalis is a place of the connection of to this different embryological tissue. And this is somehow very interesting that we know that almost all idiopathic arrhythmias originated in the heart are located in the areas where the two different embryological tissue are connected. For example, like here, this is a crista terminalis, and we know that in the right atrium, most of the atrial tachycardias originated from this area. Regagic sinus node, it's located here in the upper part of the crista terminalis, and located mostly epicardially, so and in this area. We also know that the crista terminalis, one of the way impulse propagation in the atrium. So we, it's of course no any specific conduction system in the atrium, but we know that these areas, which is has a conduction about 20% faster along this structure. That's why actually for us we understand that the atrial flutter, typical atrial flutter, it's explained possibility to have a typical atrial flutter, for example, counterclockwise in the right atrium, and why it's not going, the impulse not going, for example, around the inferior vena cava. Sometimes it can be when the atrium is diseased, but in normal situation it's going in caudocranial direction towards to SVC, then down along the crista terminalis. So when the conduction reach this area through this posterior wall, it's already in the refractory period. So that's why the atrial flutter comes in this way in mammals and in the human heart. So what we need to do, we have to ablate this area which we call cavo tricuspid isthmus. This is so inferior view, this is tricuspid valve, this is a mitral, this is IVC, and we can see this area. So if we place the catheter here, we have to ablate it in this manner, so from usually from tricuspid valve, and already here you can see the deep pouch here, so it happens very often, and you can nicely see with the eyes, and we will see it in the next presentations and during these 3 days. And of course, but to understand, I will just show you how it works. That's why sometimes this maneuver with the this curve can work pretty nice in order to ablate all these areas. This is also described in several cases that some connections can be really epicardial located and crossing this area towards to the left atrium. So you can see here, this is one of the way of impulse propagation to the left atrium. This is also explained why we have a negative deflection in the inferior leads, F waves. We can place our vectors, so then we can see that if we know that left atrium and half of the right atrium will have activation from below to upper part, then it will create a negative deflection in F wave in typical counterclockwise atrial flutter. And the opposite, if we have a clockwise, then the conduction goes mostly through the Bachmann's bundle, then activation of the most of the atrium will have a direction towards to the plus of the 2-3 AVF lead, and then it will have a positive deflection in this leads. So then we can just see how catheter looks in this area. So this is a cavo tricuspid isthmus. So this is a tricuspid valve, and you can see also coronary sinus. Usually, if you placed your coronary sinus catheter here, so usually from below, but it's better fixing from this area. So we can see that the coronary sinus is a little bit higher in direction, so my heart is now in area projection, and we do step by step, stop point by point, or dragging this line in order to create bidirectional block. We can also recognize the different thickness of the myocardium in this area. You see the pretty thin, just close to tricuspid valve. This is a ring of the tricuspid valve. We can also see the relationship with the right coronary artery, which is in this case has two branches already, and we can see the thinner or thicker part in this area. This is also important, this area where the Eustachian valve is located here. Just maybe briefly to show the EVNRT ablation, and we just also conduction system with illumination. I will show you the membranous part where the His is located. So the compact part of V node located just below in this area, and then the fast pathways are here, and the slow pathways are here. And when we ablate, we place our catheter here in this area in between the coronary sinus and tricuspid valve. So now we go to left atrium and we do transeptal puncture. So we place our catheter in SVC, and then in AP projection we go with the first and then second jump, and we going into the fossa ovalis here and to the left atrium. This is very important to understand that the fossa ovalis, the only through a septum, because the other part of the septum, so-called septum, we can see it like septum, but it's invagination of the atrium wall. So this is a duplicature of two walls, right and left atrium. And if we puncture outside of the fossa ovalis, we go to this area, to pericardial space, and then to the left atrium. And you can see this nicely preparated the Bachmann's bundle, which is here, very wide and thick structure. And then this is the main way of impulse propagation to the left atrium. So for the transeptal puncture, we doing this with the echo control with eyes, very nice, but in X-ray control we do it in the LR projection, because then you can recognize nicely how deep you're inside the left atrium. So we already discussed two ways of impulse propagation to the left atrium, Bachmann's bundle, which is main during sinus rhythm, and also along the coronary sinus here. But it's also described a septopulmonary bundle and posterior septal bundle. So the septopulmonary bundle is going from this area, actually very close to Bachmann's bundle, and then going to this area. And with the transillumination, we can see that the sum of these fibers are ending or going towards to this carina in between the right veins, and some of them to the posterior wall. And the problem is that if you make a histological cut here, in between these fibers can be fat located. So this is one of the obstacles for energy delivering, and they are epicardially located. That's why sometimes we can see the gap in this area. So that's why the line between right veins or maybe sometimes narrow isolation can be helpful to reach isolation. Furthermore, it's described some direct connections from the right atrium towards to the right superior, for example, vein. You can see here, this is a nice small fiber connection towards to this right superior pulmonary vein. Regarding then the fibers orientation, so we can see it here. And maybe I will switch off like this. And then we can see that the anterior wall with the Bachmann's bundle is the thickest part of the left atrium. And then fibers going towards to the mitral valve in this direction, then some of them going to the roof and posterior wall, and then some of them surrounding between the left atrial appendage and the left veins. And we can see they are going this way and in this way, and connecting here in the posterior or inferior wall. And what we can also see here, this is a different orientation of these fibers. So in the cardial and the epicardial, they are located in the different directions, which can also create some difficulties to map the arrhythmia in this area. So we can also see these nice circular fibers in the pulmonary veins here, which are trigger activities for atrial fibrillation. So now I will switch to VTs, and we just briefly start with RVOT arrhythmias. It's the same. We know that they are originated from one structure. So the truncus arteriosus is a form aorta and left ventricle and right ventricular flow tract together with the pulmonary artery. So it was one structure embryologically. And we can see the relationship, the spiral relationship. This is superior view. You can see central orientation of the aorta and the superficial anterior orientation of the right ventricle outflow tract. For us, it's important because we understand that we place again our ECG leads. So this area is very superior oriented, and we will have a positive deflection in 2-3 AVF. At the same time, we can see it here with the precordial leads that this is the area. This is one lead here, so we can see that the area which is located close to V1 will create the QRS morphology of QRS, because the vector will be directed to this direction. At the same time, the positive deflection in V6, and everything which is originated from this area will have the opposite picture. We can see also that the aorta and cusp are located a little bit lower, so we can see the close relationship, these myocardial fibers, with the aorta and with the cusp, and probably sometimes we can ablate some arrhythmias from this area, which is originated from the left side, and the opposite in this area. So from the practical point of view, we have to be ready to map all these surrounding structures during our procedures, during ablations. So this is also very, very important for us. Lead 1, we can also see the lead 1, and if we make a kind of line, then everything which is originated from this part will have a positive deflection in lead V1. Everything is originated here will have a negative deflection. So what it means that the part which is highest part here in right ventricle outflow tract, especially this area here, which is anterior and the left cusp of the pulmonary artery, then it will have a negative deflection. In the same time, if we can see this right coronary cusp here, will have can have a positive deflection in lead 1. So this is our three main vectors, I would say: precordial leads, triangle Eindhoven, and lead lead V1. So what we can see also, different projections, the close relationship to these areas. This is the aorta, this is a pulmonary artery, this is a non-coronary cusp, right coronary cusp, left coronary cusp. And if you can see here, this is a right coronary cusp, which is really closest to the right ventricle outflow tract. And it's contacting mostly to the right ventricle outflow tract, compared to, for example, left coronary cusp, which is here. We can also see already here the close relationship with the right coronary artery of this area, and we can recognize it also here. This is right ventricle outflow tract, pulmonary artery, aorta, right atrial appendage, and you can see the close relationship with this area of the right coronary artery and the LAD in this point, especially when we have this kind of pouches here, and the pouch and the pop effect, for example, and then there is several cases described of the damaging of the LAD artery. And I will finish with one of the most difficult area, which is LV summit, and this is the upper part of the left ventricle. So the LV summit is actually a term created by an electrophysiologist, not by anatomist. And what we can actually see, this is the area which is the upper area in the left ventricle. It's located here, and I will show you in different cuts here. And already here you can see the relationship with different structures. This is a pulmonary artery here, this is a fat here, and this is LAD is located here. That's why epicardial ablation of this area, especially pericardial located, can be difficult, but some of the area here, so-called accessible area pericardially, it can be ablated. You can see here no fat, but at the same time, if we can see another specimen, for example, in this, you can see it's heavily covered by fat and almost surrounding whole LV summit and lateral wall of the left ventricle. At the same time, we can see this close proximity of the distal part of great cardiac vein and anterior interventricular vein, and you can see we can use this for mapping, for ablation, and actually also for bipolar ablation. So we place one catheter in this vein, and the second ablation catheter here. We can make a bipolar ablation in between these two catheters. But if we're going again, which area can be used for ablation in this field, we can see it here. So this is here right coronary cusp, left coronary cusp, and we can place our catheter here from the left coronary cusp. We can go below aorta and place a catheter here, endocardially along the mitral valve. We can go through the vein, we can go epicardially, we can map and maybe ablate from appendage, but it's probably very dangerous procedure, so in terms of perforation, because you can see the left atrial appendage usually lay above this area, and it can be used during our procedures. So I don't know if I have several minutes for questions. Thank you for your attention.
So we have about 4 minutes for anybody has question or comment. It's very interesting to see that sometimes you have so much fat epicardially, and this explains why sometimes we may not see even signals epicardially and may not ablate even with pulse field, actually, because this is like insulator, this epicardial fat. And probably in our population where BMI is really going up, that might be a problem for ablations epicardially.
Maybe just briefly to show you one really interesting specimen, which is a scar here, and what we can see. So usually we have a endocardial scar and we plan endocardial procedure, but what we can nicely see, this is a almost transmural but not transmural scar and survived myocardium, which is for us area with slowing conduction, is epicardial located. That's why it's in this case ablation of the VT should be done epicardially in this case.
Questions or comments? There is one question. Do we have microphone?
Evgeny Land. Yeah, Evgeny Land, Germany. Maxim, thank you very much. Fascinating presentation. I just wanted to ask. So you show these all structures in the LV segment and how thick this fat layer is. Would you say it is, if I'm about to burn from epicardial, so epicardial layer of these structures, does it make sense to go epicardially, so through the epicardial puncture, or the better way just to go through the vein structure, and apply some alcohol ablation or RF ablation, bipolar ablation?
Yeah, so it is a good question. As I said, there is a different from patient to patient. As you can see here, this is not so covered by fat. We can use preoperative imaging, and now we can see all this fat. And if you can see the heavily covered this area, then I think better to go into the vein. And as you said, we can use alcohol ablation. And this is very nicely went through, actually accidentally, but you can see this small vein which can be used for alcohol ablation and to ablate all this area here, surround, and in this area, which is also can be used in the atrium. And just briefly show you the vein of Marshall, which is here, which is going into the border between the coronary sinus, which is covered by muscles, great cardiac vein, and you can see here. And you can also nicely see that even if you fill it with a silicone, blue silicone, you can see that all this area are filled with the silicone. It means when we infuse the alcohol, all this area will become the scar here. So this is also a nice demonstration of the anatomy of this structure, which is vein of Marshall.
Okay, I think we have to continue. Thank you very much, Max, for this overview of anatomy. And it's my pleasure to introduce the next speaker. And this is Dr. Mansour Azminia from Elgin in USA. And he will talk about intracardiac echocardiography for electrophysiologists. He published, I think, 2 books about intracardiac echo. So he's one of the experts in this field. He does all his procedures just with intracardiac echo, so no X-ray, which is a level which I probably never will reach because I'm used, I was brought in the past with fluoro only, so I like a little bit of fluoro, but not that much. But
thank you so much.
Mansour is using only ice.
Yes. Thank you very much, Dr. Kazner, and thank you for this invite. It's a great pleasure and honor to be here among you folks. Speaking of my experience with the intracardiac echo. All right. Can I start? Can I start? Yeah, thank you. All right, these are my disclosures. So we're going to be just talking about catheter ablation of PVC today. This is a, as you know, this is a RVOT. My ICE catheter is inside the right ventricular outflow tract, and those are the pulmonary artery, right and left coronary cusp. Let's take a look at this image. If you notice here, you see that my ablation catheter is coming into the pulmonary artery. But I want you to notice something. That ablation catheter is in the posterior wall above the pulmonary valve. And actually, the pulmonary valve right there that can prevent ablation catheter from having a good contact with the posterior wall because of the valve. So what can you do there? When you see it, it makes most sense just to go ahead and perform a U-curve, like a candy cane. When you make a candy cane and bring it down, you're going to be now above the valve, and the valve is not going to have any issue, it's not going to cause any problem right here. Why? Because I'm completely connected to this valve right here above the valve. So, but this is an upside down view, remember? This is what we have placed. So you can press on the button on the top, which is this one, and make it right side up view. So what you can, on the monitor, on the machine, on the one that you have, just make it, right side up view. And this is how we can see the RVOT, we can see the pulmonary artery. And this is the ablation catheter. I have performed a candy cane, and right now I'm right in front of the, pulmonary valve. So you see that how easier it becomes to understand where you are in the heart. It is like you are in this room and you see where the PVC is coming from. You understand it, you feel it. It makes it much easier to perform the procedure. But at the same token, you see here now, I'm going to bring it down. Actually, I'm checking the PVC under the pulmonary valve. You can appreciate. But remember, what is we just looked at such an elegant, cases of anatomy. What is on the other side of this is, of course, right coronary cusp. So you can go ahead and place your ablation catheter here as opposed to when it was right here. So right now, my ablation catheter is in the right coronary cusp, as opposed to a few seconds earlier, which was in the RVOT. So you would be able to see where exactly this PVC is coming from, where is the unipolar, how the unipolar looks like, how activation is, and just go ahead and ablate it without having any issue. And also at the same token, you would be able to see that ablation in the long axis view. So here you can appreciate it. This is the ascending aorta. This is ablation catheter. When you see the pulmonary artery, this is always left coronary cusp. So because left coronary cusp is on the other side of the pulmonary artery, so we are above the pulmonary valve. So here, you can appreciate now I'm just look at this view, and now I'm bringing my ablation catheter right here and going above the pulmonary valve on the other side in the pulmonary artery, just to see that which one is the best area just to go ahead and ablate this PVC. Of course, you would be able to see those coronary arteries also with your intracardiac echo. Let's talk about an example. Again, sometimes you say, I've heard Dr. Asirvatam very elegantly always talk about this. Look at this RVOT. You can appreciate this is a pulmonary valve and pulmonary artery, and you can appreciate this is extension of the RV muscle into the pulmonary artery. And actually, this is where my PVC was coming from. So I was able to very nicely go ahead and place my ablation catheter right there and ablate the PVC from right that area. We can also see the short axis of the pulmonary valve. This is a pulmonary valve from the SVC. This is very good. Why? Because now you can see a short axis of the pulmonary valve with all the cusps, right, left, and anterior cusp. And that's the aorta, that's the left atrium. It may help you if your pediatric colleagues are going to be able to go ahead and perform a transcatheter pulmonary valve replacement that I'm going to show you. So this is what you can see it from the SVC. But if you also go ahead and place your, ICE catheter inside the left atrial appendage, very close to the apex, again, you would be able to see the short axis of the pulmonary valve. This is very interesting because I have never seen probably be able to see it with the TE, but you would be able to see it now, the opening up, and this is actually a case of the a transcatheter pulmonary valve replacement that they had performed. You can see the struts right here, and you can appreciate that that is the pulmonary valve, which was the trans. So you would be able to, that view, when you know it, it's your friend. It really makes your life much easier to be able to perform these catheters. Let's talk about one case. So this is a PVC coming from the right ventricle, okay? So this is a right atrium, right ventricle, and this is RVOT. If I ask you where the ablation catheter is, you're going to tell me that this ablation catheter is somewhere inside the right ventricle at the orifice of the RVOT. Never be satisfied with this view. Why? Because my ICE catheter is right there on the top. My ablation catheter is here. I'm too far away from my ablation catheter. Always try to advance your ICE very close to your ablation catheter. How do I do that? This is a sample. This is performing anterior tilt with the ICE catheter, place it into the right ventricle. So let's take a look to see how we look at it on the ICE. So here you can appreciate that we have the ICE. So that is those two dots. That is the tricuspid valve. Remember? That is the orifice of the tricuspid valve. So where is my ICE catheter? Any ICE catheter, any platform is different. But in this one, you can appreciate these are two dots there. Those two dots is your transducer. So those two dots would always tell you where your ICE catheter is. You may have a V, you may have a line, but whatever you see on the top, that is your transducer. And you can see, appreciate, this is a transducer. So the head, your hand is here, ICE catheter is coming here, and you are looking down with those two dots, being able to see it. So, but remember, those two dots would never move on the platform. On the screen, those two dots always are going to be there. So what in reality you're going to see the heart structure would come up. Those two dots would never go down. So imagine that what you want to do right now, you just want to go ahead and place this ICE catheter where? Through the tricuspid valve, going to the right ventricle. That dot is not going to move. So in reality, you're going to see the tricuspid valve is coming up and getting horizontal and getting around that two dots. So let's take a look at it. So as I'm performing anterior tilt, now those two dots are where? Are inside the right ventricle. So now I know that my ICE catheter is inside the right ventricle, and this is the tip of my ICE catheter. One thing that you always want to see, you want to see black in front of it, which is blood. And what do I see right now? I have a little bit of tissue. If I advance, I'm going to perforate. So I immediately know that I should not advance anymore because I see the right ventricular tissue. So the same thing. Why do I have to be happy with the image that I just had? I'm not happy. So what I'm going to be doing right now, I'm advancing the ICE inside the RV, and guess what? Look at this ablation catheter. Ablation catheter is right by the papillary muscle inside the right ventricle. So I see it so detailed, but at the same token, I was noticing that I didn't have a very good unipolar. So I said, let me just place the ablation on the other side of the pap muscle. You just go on the other side of the pap muscle. It is really, you're looking something in our house and just see if it is in this room, is it on that room? So you would be able to understand it much better, to be able to manipulate. And this was a redo from another center. So another case. If I show you the same thing, you're going to say, oh, are you still by the papillary muscle? No, I'm not by the papillary muscle. I don't know where I am. Why? Because my ICE catheter is there. My ablation is here in the RV. Again, I'm at the beginning of the orifice of the RVOT. What am I going to do next? Perform anterior tilt, go inside the right ventricle. And guess what? I'm completely in a different location. I'm on the septum of the RV. So my ablation catheter is right here. You see the LV. If I perform a little bit counterclock, that is the RV. If I perform a little bit counterclock, I would be able to see my ablation catheter right there. Okay? But then you can also see, oh, maybe this would be coming from other end. Just you see it right now. When I see it, I just went ahead, I placed the ablation catheter inside the septum in the LV. So sometimes you need to do a bipolar between these two. But it is going to make your life much simpler and easier by having this catheter here in the RV, the same person, the same procedure, putting in the LV. And then, interestingly, as I was ablating here, this is what happened. This is a stim pop you can see. You can see, many of them you don't even hear them. You have so many stim pops that you are not aware of. And we call them like a crater. Why? Because they really look like a crater. And this crater, if it is happening in the septum of the RV, nothing is going to happen to that patient. But God forbid, if that happened in the free wall of the right ventricle, chances are that you have to call your cardiac surgeon because so you want to be careful. Here, I'm going to be very careful with echo density of the tissue, how much power I'm going to deliver, because this is a free wall. This is a septum. So I know I'm in control. The catheter is not in control. We are in control. I'm going to show you 2 cases of the middle cardiac vein PVC. So let's take a look at it. Is it a little bit anatomically, you have to pay attention to this right atrium coronary sinus, LA. And you see here coronary sinus, and what is this catheter? You all know. This is going to be coronary sinus catheter. And remember, the CS is very close to the left atrium. This is the left atrium. This is a coronary sinus. But when I counterclock, there is another vein. What is this vein? This vein is going away from the left atrium. You see, it is going towards the what? Towards the left ventricle. So that is the middle cardiac vein. If I go and perform a little bit clockwise rotation, that is the middle cardiac vein. Remember that. That's not the coronary sinus. If I perform just tiny little bit clockwise rotation, that is the coronary sinus. That is the left atrium. And look at the distance between the coronary sinus and the left atrium, which is few millimeters. I clock it more, I can see the CS catheter, and I can see the CS. I'm not going to ablate inside the CS. I'm not talking about ATAC or AFib. I want to ablate the PVC. What do? I perform a little bit further counter. I'm still seeing the coronary sinus. And then I would be able to go ahead and perform a little bit further counterclockwise rotation, and I'm going to be able to see middle cardiac vein. So this is where your middle cardiac vein is. And now this is interesting. One thing I want to show you, left atrium coronary sinus, this is the esophagus with a lot of air in it. And you can see the esophagus all the time. And interestingly, the patient had a small burp, and you can see all the air came out. So you see so many interesting with ice that there is no way that you would be able to see it with mapping or X-ray. But that is interesting finding on the same patient. So where is my ablation catheter right now? The ablation catheter is inside the coronary sinus. Am I going to burn it here or do anything mapping? Absolutely not. We are talking about the PVC. And you can see that this wall between the CS and the left atrium is too short. But now I counterclock and I place my ablation catheter inside the middle cardiac vein. You appreciate that middle cardiac vein? Right there. So you see the middle cardiac vein is going away, and you have a distance between the middle cardiac vein and the left atrium. But interestingly, with the ice, this is posterolateral branch of the right coronary artery. You can see it. You can even go and perform, a color Doppler, and you would be able to see that right there. That's the PL branch of the coronary artery. So you know that you definitely need to call your interventional colleague to come and do an angiogram. Specifically, look at this case. I can see my ablation in the middle cardiac vein, but guess I'm between those two, sandwich between PL1, PL2. You can see the PL1, short axis of the PL1, short axis of the PL2, and you can go ahead and have your interventional colleague to do an angiogram, and guess what? I'm sandwiched between the PL1 and PL2 right there. So that's the coronary sinus catheter. Remember, I'm away from the coronary sinus. I'm here, PL1, PL2, but I'm very close to both of them. I don't want to, absolutely don't want to burn there because you know that you're going to cause trouble. Of course, you may just be able to do cryo, but then I was lucky enough to advance the ablation a little bit further. You can see ablation has gone further inside the middle cardiac vein, and you can appreciate that I'm much farther away from the PL branch. You see that? So I know that this is a safe area, but still I don't trust that. I have to continue doing the angiogram, and I see I'm both away from the PL1 and PL2. So it is a safe area to go and do your PVC ablation, which is coming from the, middle cardiac vein. You see that my ICE catheter is inside the right atrium. I can see that directly down here. again. And here with the electroanatomical mapping, you can see the tricuspid valve, SVC, CS, and this is where the middle cardiac vein is. And take a look at here. This is actually very interesting. I'm about 33 milliseconds early, and I have a QS on the unipolar. So it is a great area. I'm safe. I'm away from the coronary artery, and I can go and ablate it. And we had a successful ablation for this patient with middle cardiac vein PVC. And you can see that, of course, you have the mapping. I always use mapping along with the intracardiac echo. I haven't used X-ray for over 14 years now, which that's why, because you understand it. And when you understand it, you would be able to see that what is X-ray is going to help me. Of course, if you're going to have a coronary angiogram, you absolutely need it. But here we go RF1 right here, and you can see that we have some automaticity here, and the same PVC, and then PVC disappears, gone for good. This case was done about 2 years ago. I have seen the patient 3 times after that. We never had a recurrence. But this is another example. I did this procedure about a month ago. So this is interesting. Another PVC, and again, this is coming from middle cardiac vein, but it is a little bit different. So you can appreciate again, that was my PVC. And take a look again. So do you think this is CS or middle cardiac vein? It is middle cardiac vein because there is a distance between me and the left atrium, but at the same token, you can see that this is a middle cardiac vein. But what is on the other side, it is also posterior aspect of the mitral valve. So this is my ablation catheter going right here, and I had my interventional colleague do an angiogram, but you can see I'm far away from it, but I'm really not, because you had to do another angiogram from the left coronary artery, and you can see actually this is a dominant, and PL was coming actually from the left. So if you see, you have to really pay attention and make sure that you are not going to be ablating 1 millimeter away from this PL branch, which is coming from the left coronary artery. So what I did, this time, I was lucky to bring it back a little bit, and I had the best activation right here, and when I did the angiogram, when I pulled it back, I am nice about maybe 8 to 10 millimeter away. So this was a great area that I was able to go and ablate. And here you can see 31 millisecond earlier, and I had a great unipolar. But then I went ahead, I ablated that. But then just to make sure that I'm not going to have this patient come back. Take a look at this. I put the ablation on the other side, and I just did both sides of this area, just to make sure this patient would never come back. So this is a mitral valve. I'm under the mitral valve. Here, this is on the middle cardiac vein. So when you see that, this is the same patient doing the same procedure, but I have gone under the mitral valve in the posterior aspect by the other end of the middle cardiac vein, and I was able to ablate this PVC with no problem. Here you can appreciate again, we go RF1 right here, and then as soon as we go RF1, the PVC is eliminated. Let's talk about the PVC from endocardial aspect of the LV summit. Let's just talk about, this is the PVC that the patient comes with. It has the endocardial aspect of the LV summit. We're going to take a look at to see anatomically what we have. So this is my ICE catheter. From the home view, if you perform a little bit clockwise rotation, you would be able to see this nice view, which is going to be, if you are going to be using it from McAlpine, which is a blessing that we have this now in, to be able to use it. But you can appreciate that that is a aorta, that is a pulmonary artery. So this is the, and that's the thickness of the endocardial to epicardial. So you can appreciate endocardial to epicardial. If I perform a little bit clockwise rotation, what am I going to see? I'm going to see the left main. So I know that epicardially, we are going to be under the left main. Endocardially, we are going to be under the left coronary cusp. Here, as we just saw on the anatomy very beautifully, you can go ahead and perform a candy cane. Make a candy cane, bring the ablation here, right, coming down, and make it candy cane right here. From here, it comes under that very left coronary cusp, adjacent to the right coronary cusp. So this is that juncture between those two. And you can see that as I'm ablating, you can see the tissue is becoming very white. It's really so fun to be able to see this. You can appreciate the tissue is becoming white, so you know that you are causing some effect. And then you can also look at this in the short axis of the aortic valve. If I just go into the right ventricle, where is my ablation catheter? At the juncture of left and right coronary cusp. So this is my ablation catheter underneath of that left coronary cusp at that junction of those two. And then again, you can appreciate one more time, this is ablation catheter in this region. And here, as soon as we went ahead and we went RF on, within few seconds, endocardially, we were able to ablate this PVC from endocardial aspect of the LV summit. So really, ice helps you because it really tells you where you are. And here you can see, sometimes I stay there for up to 2 minutes, 35 watt, just go low on the watt just to be able to create a nice. If you don't see this in the LV, chances are you're not going to be successful. You want to see a lot of echogenicity of the tissue wherever inside the LV. The tissue is thick, and here sometimes you can see, excuse me, go straight down. So you may have a little bit more contact force with that area. Let's talk about the case of, excuse me, aortomitral continuity. And this is a mitral valve annuloplasty. And we are going to advance the catheter. Usually you want to go retrograde for it. It is aortomitral continuity, of course. You want to go retrograde. I will tell you why I had to go antegrade in this case. You can appreciate that this is the left atrium. My ablation catheter is coming, going towards the aortomitral continuity, which is somewhere right here. So what you see here you can appreciate left atrium, mitral valve. This is the LV, and this is a mechanical aortic valve. That's why I could not go retrograde. And this PVC is coming from under the mechanical aortic valve, and it is right here. But I am in control. Look at that. The moment I see the ablation catheter, I don't see the mechanical aortic valve. You see that? But when I go and perform a little bit counterclockwise rotation, I see the mechanical valve. I don't see very clearly the ablation catheter. So I know I'm about 8 millimeters away from that mechanical aortic valve, and happy to be able to ablate and eliminate that PVC which was coming from under the mechanical aortic valve, and it was an aortomitral continuity PVC. And you can see the lesions right there. So let's just talk about a little bit about pap muscle. Really, pap muscle PVC could be your friend rather than the before. Because if you understand the pap muscle, it would be really sometimes like as if you are doing a flutter ablation. I'm honest with that, if you understand the ice. So why? Because we place the ice inside the right ventricle, we just go and perform clockwise rotation. So the first pap muscle you're going to see is posterior medial pap muscle because it is sitting on the posterior wall. When you go and perform a little bit further clockwise rotation, you're going to be able to see the anterolateral pap muscle, and that is your anterolateral pap muscle, which is away a little bit from the posterior wall. If you prefer, you can press the right and left. I'm sorry that I have to do that because that's how I understand. I just do the right and left, and the icon comes to the right. And why do I do that? Because this reminds me of parasternal long axis view of the 2D echocardiogram. Left atrium, mitral valve, LV, anterolateral pap muscle, and LVOT. So this is how I'm going to show you during the pap muscle ablation. But how do I understand which pap muscle is which? So remember, the posterior medial pap muscle, at the moment you see the septum, you go clock it more, you see the posterior medial pap muscle, which is sitting on the posterior wall, okay? So that cannot be anterolateral pap muscle because we just haven't clocked it yet. If you go and perform further clockwise rotation, that guy goes away, that posterior medial pap muscle would go away, and you're going to have an anterolateral pap muscle, which is right there, and you can see it is anterolateral. So it is not sitting on the posterior wall. There is a distance between the anterolateral pap muscle and the posterior wall. So that is how you know which one is which papillary muscle is which. But it can become your nightmare, specifically if you're just going to use X-ray to know where you are. But as I'm going to show you, when you are going to take a look at with the X-ray is going to be really your friend. So let's take a look at this. This is anterolateral pap muscle. But what is the problem? We have gone retrograde. You know that retrograde is not the best option for anterolateral pap muscle because I'm not sitting on that area. I'm teetering. Take a look at the ablation. It is not sitting there. It is right here. It is teetering. It is not sitting on that area. You see that? I'm not going to be able to have a successful procedure. There is a story behind it I can explain later. But I decided to go transeptal puncture. So now, again, I go and put the icon on the right. So I'm coming left, remember, left atrium. My ablation is coming through the mitral valve, going to the left ventricle. Where is going now? To the LVOT. So what am I supposed to do right now? I'm going to remove the curve and pull back a little bit. As soon as I remove the curve and pull it back, I'm going to find this is the same patient, remember? Now look at how it is snug to the tissue. You see, look at this, compare this one with this one. So this is a retrograde. Remember, for anterolateral pap muscle, you always go antegrade, which is transeptal, and compare it to this one. Tissue has already become white, and I'm having a very good lesion, impedance drop, and I'm going to get rid of that PVC, as opposed to the one which was not sitting there. Let's talk about another example. This is, let's see. This is, again, you can appreciate the M shape. Transition is here, which is, in V5, but it is a little bit different. 2, 3 AVF are not neither completely positive nor completely negative. So it could be some tricky. Let's just take a look what it is. So I look at the posterior medial pap muscle, correct? So this is my posterior medial pap muscle. If this PVC can, if you put it on the Google map, really, it can be coming from any of this area. So guess what? Go ahead and use the X-ray and tell me where this is. Use X-ray if you need to, but use your mapping, but particularly use your eyes. Why? These are 3 heads. I did this procedure about 3 weeks ago. This is brand new. I have never presented anywhere. So these are all 3 anterolateral pap muscle. And guess, again, put the Google map. Where is this PVC going to be coming from? Any of that areas, the PVC may be coming from. So it is going to be a nightmare that you're going to be a Friday case. You say, oh, let's all go home, and you order the tomorrow breakfast, and you're still in the lab. But you shouldn't, because when you see that right there, this is my HD grid, and you would be able to go in between, and while you're also creating the geometry, at the same time, you immediately know where it was coming from. And go ahead and put the ablation that burn it, because you can see it live. So this is my ablation catheter. It is in the anterior aspect of the anterolateral pap muscle. Now where is it? It is between these 2 anterolateral pap muscle. Agree? You see, it is in that area. I'm checking it. There is another anterolateral pap muscle. I'm not checking it yet because I need to keep going and to see where it is. Now I came between these 2. So I'm going retrograde, remember? There is the LVOT, and I'm right now between those 2. So this is anterolateral, but I'm between these 2 heads of anterolateral pap muscle. Okay? So now, what did I do? I just came to the posterior aspect of the last head of the anterolateral pap muscle. So this is still anterolateral pap muscle, and this is the posterior head of it. And the PVC was coming right from here, exactly from here. But I still had some issue. Again, because this is anterolateral pap muscle, I was not able to get any good contact force more than 1 gram, not at all. So here, if you appreciate, I just went ahead. Again, I went antegrade, perform a transeptal, go there, and go through the left atrium, through the mitral valve, go to the left ventricle, and this is LVOT. We don't want to go there. We just want to come here and place the catheter right somewhere here. Let's take a look at it. Here, I just went. You see that ablation catheter is right there. I'm already having a great contact source. I already started burning because you see that tissue is becoming white. The ablation is coming through the mitral valve. Tissue is becoming very white. And then take a look at it. I went to the other side of it, and I just saw that maybe this was a great PVC. Maybe there was exit changed. So I just went ahead. I performed ablation right there as well. So I did both anterior and posterior aspect of this head. But take a look at it. When I go down counterclock, I see the posterior medial pap muscle. Do I see my ablation catheter? No. There is no ablation catheter there because I counterclocked it. In order to see the ablation catheter, what should I do right now? I have to clock my eyes to be able to see the ablation catheter. So you know, when you see this, you know exactly where your ablation catheter is. I was not anywhere close to the posterior lateral pap muscle. And again, as we started our fun here, we had a good automaticity, and a few seconds later, we were able to eliminate these PVCs. Again, these PVCs really can be your really friend if you use the eyes at its best so you can see exactly where you are at every moment. You always have to see your ablation catheter very nicely and get close to it as much as possible. For papillary muscle, another example. Papillary muscle PVC, LV. Where is my ablation catheter? It's in the posterior aspect of this posterior medial pap muscle. Take a look at here. I'm very good. I'm very early. It's about maybe 35. But what is the problem here? Take a look at this unipolar here. Sorry, that went away. So that unipolar had a small R wave on it. So I didn't really like that. So I said, here, let me just go and take a look at this here, bring it to the other side of this pap muscle. I had the best unipolar. So I immediately have the very good, activation, and unipolar got a QS beautiful. Everybody started drooling on it, and we started burning, really. And you can appreciate that is, how white it becomes, and you know that you are delivering a very good lesion and getting rid of that papillary muscle. PVC. Let's just talk about another 15 minutes, a little bit about safety issues with the eyes. Take a look at this. These are the cases that if you don't use ice and you don't put your eyes inside the left atrium, you won't see them. This guy has a thrombus on the ablation catheter. So what you do, if you don't know about it, you pull your ablation catheter out and you say, oh, this is clean, perfect. Yes, it is in the brain. It went to the brain already. So what you can do at this stage, as you are gently pulling it back, you aspirate from the other end, from outside of the body. Get a 20 cc empty syringe, and as you are pulling it inside the sheet, you see, I'm pulling it inside the sheet, you see the thrombus is still here. You see the thrombus is moving. That's the thrombus going inside the sheet. But I'm aspirating from the other end in the right groin, or left groin this is let me see, patient is here, yeah, right groin. So, and then this is a sheet, so the catheter just came into right there. The clot just came into the sheet, and these are the clots you can see. So these are the ones that goes to the brain, and we call them probably ACE, asymptomatic cerebral emboli. The reason they happen because we don't see them on the eyes. That's why you have 40%. I haven't had a study to prove it, but this is another one. Take a look at this. This is a transeptal sheet. This is a ring. This is, I call it the ominous ring, or ACE ring, asymptomatic cerebral emboli. When you see that, pull it gently inside, but if you don't aspirate from the other end, this is in the brain. This is another one. So if you don't see it, you're looking at the X-ray or you're mapping, you're pulling it back inside the sheet, it already went embolized into the brain. But when you're pulling it back, aspirate from the other end, so bring that one inside the sheet. Look at that, now I'm inside the sheet, and this is the same patient. Look at that, I did it a little bit slow motion, so you see that ring just appeared right there. You can appreciate that. This is during the procedure. I have a collection of them at home in the jars. Honest to God, I wish I had brought them. I don't know if I brought any, but I have a collection of them. I see so many. This is another case. As I'm performing the AFib ablation, take a look at that wall, see what has happened. So this is my mapping catheter inside the left superior pulmonary vein. But take a look, I just had started burning. And that's the mitral valve, that's the left ventricle. So my eyes is inside the left atrium. And you can appreciate when you see those two dots are inside the left atrium. So you know that I always put the eyes very close to the ablation catheter. If I'm doing left-sided ablation, it's always in the left atrium. So now take a look at this guy here. So if I don't know about this, I'm going to just move my catheters. I would never know about it, but look at that. I just had performed a lesion there for 10 seconds, and I saw that. So those are the small things. God knows if it is going to cause what in the future, dementia. I don't know what's going to cause, but I know how to get rid of it. So I removed the circular mapping catheter. You can appreciate, I just removed the circular mapping catheter. I'm going to bring the sheet very close to that area, and I'm going to aspirate it. I just went there, I aspirated, I got rid of the, it was interesting, the shape of this, I never forget. It was as if it has happened there for ages, but it happened right during the procedure. This is the one I just retrieved. If I hadn't retrieved this, this would have been in the brain of the patient. Another case of probably, again, I don't have to prove, but I don't have the case to prove it, but it could be asymptomatic cerebral emboli, and you see that gone. There is no further of any thrombus on that wall. I aspirated it, it's gone. Take a look at it. This happened 3-4 weeks ago, about 5 weeks ago in our lab. This was actually from last procedure 3 years ago. This, I haven't even started doing anything. I just had this one. I looked at it before, embolizing it to the brain. I just went ahead, I decided to remove it, and I saw it this. So I saw this too, and I sent it to our pathologist. I said, what do you see? And she says, acellular, which means this was a thrombus, which a little bit of calcification stuff there probably. And then this is, what she said, probably it was a thrombus in between after 3 years of you did the ablation. And now I could have embolized this, but I found it, I removed it, I sent it to my pathologist. And you don't see any cells here. And this is an interesting case. I want to pay attention to this. 56-year-old woman. So I had done an ablation of long-standing persistent AFib 4 years ago. So she developed ATAC after 4 years. She come to see me. I did an ATAC ablation from anterior aspect of the left atrial appendage. ATAC terminated, but left atrial appendage got isolated. So what do you do for this patient? We scheduled for Watchman in 3 weeks on uninterrupted DOAC. And I did a TE 1 week prior to Watchman. There was no left atrial appendage thrombus. So I bring the patient for Watchman. I did a TE 1 week ago, nothing. So let's go ahead and do the Watchman, because if you do left atrial appendage isolation, if you don't put the Watchman, you're in trouble. Look, so let's take a look at it. I'm placing a Watchman. My ice is where? My ice is inside the pulmonary artery. What else do I see? Left atrial appendage, left superior pulmonary vein, and this is a transverse sinus. Okay? So as I'm starting to do this procedure, let's look at this finding. So this is also, you can see the color Doppler across, and let's start looking at, this is again the transverse sinus. So majority of time you see this transverse sinus. This is not the edge of the appendage, remember, edge of the appendage is here. But look at this, what happens to the, right there. This is a thrombus inside the left atrial appendage. 1 week before then, we didn't have, we didn't have anything. I had my interventional colleague to put a sentinel device. So this is coming, the sentinel device going to the left carotid. You can see here filter, another filter in the right brachiocephalic. Actually, I helped my interventional colleague to be able to place that with the ice by putting the ice way up here to be able to see left carotid. So I put it in the left brachiocephalic vein. So let's take a look at the ice, see how it looks like, this sentinel device. Where is my ice? In the SVC. This is aorta, and this is a sentinel device. Coming from the brachiocephalic artery, that U curve, remember, going to the left carotid artery. So this is a filter in the, so again, my ice is now in the right brachiocephalic vein. I can see the filter inside the right brachiocephalic artery, and if I counterclock it a little bit, you appreciate that this is coming right here and going to the left carotid artery. So we were able to make sure that we protect those areas. And look at this. Now, where is my ice? My ice is inside the left superior pulmonary vein, because those 2 dots are in the left superior. This is the best location to deploy your Watchman. This is the transverse sinus. Remember, this is not the edge of your appendage. That's the transverse sinus. You have just one chance to be able to go ahead and deploy it. And I just went ahead, and as I'm looking at, remember, this is not, I'm not going to bring this one here. I'm going to do it inside the appendage, right there, and I deployed the Watchman, and I was able to jail the, I don't want to send a 56-year-old woman for open heart surgery to remove that one. You would be able to see, and then this is happening despite the fact that she has been on anticoagulation. So please, if you are going to do left atrial appendage isolation, Watchman immediately. So this is the same case. Again, you can appreciate my ice is inside the pulmonary artery. What is this structure? Transverse sinus, remember? And this is my Watchman, which is already causing some clot in it, a big-time transverse sinus, which is physiologic. You always see that. And here you can appreciate that I have jailed that thrombus in the apex of the left atrial appendage, and this is a Watchman device. So we were able to jail that thing. So let's just talk about another case, how it is going to help you significantly. This is a case that I'm going to do a TAC inside the left atrium. So let's take a look at that. So what do I have here? This is my ablation catheter, and you saw my ablation catheter right there. And what comes to the view? My ablation is inside the SVC. And do you see that white thing right there? That's a phrenic nerve. So you would be able to already know where your phrenic nerve is. You don't need to keep pace. You can pace and keep doing, but look at that. I see that I'm far. This is a phrenic nerve right here. And I may be a little bit far, 5 millimeters. Look at that. I'm about 1 centimeter away from the phrenic nerve because this is a phrenic nerve. My ablation is inside the right atrium. This is ablation catheter. But when I'm pulling back the ablation catheter right here, I know that I'm not going to burn anymore because I know immediately I'm going to have diaphragmatic pacing because look at this, 2-3 millimeters from the phrenic nerve. So I'm proactive. I already know that I have already stopped ablating there. But I keep pacing, but I'm not going to do any further ablation because I'm going to damage this phrenic nerve. So it helps me to visualize, to be able to do this procedure. You see, look at how close I am, and you can see we are already pacing the diaphragm. You can see that. That's the hiccup of the diaphragm we are pacing, that as we are ablating. And then this case was very interesting by using the ice, why it really helped me. Let's explain to you. This is ablation catheter, okay? So that is ablation catheter. My ablation catheter is inside the lateral wall of the right atrium. This is a physiologic pericardial effusion. They all have it in the lateral side. It may be less or more, but they always have this a little bit physiologic pericardial effusion in the lateral aspect of the right atrium. My ice catheter, those 2 dots are inside the right atrium, remember? So I was able to see that. So you can see that ablation catheter, and you can see the artifact here of the ablation catheter, okay? But this is a phrenic nerve. And the problem is what? My PAC was coming right, ATAC was coming right here. And take a look at this. As soon as the patient takes a deep breath, the physiologic effusion goes away. You see that? There is no effusion, so I am doing diaphragmatic pacing. Look at that. I'm keep pacing, but the moment patient takes a deep breath, the effusion goes away, and look at hiccup. That's a diaphragmatic pacing. So what can you do in this situation? I just spoke, you have to have a very good anesthesiologist to tell them that hold the breath and the expiration. So I had them to hold the breath, end of expiration. I had a lake here. Inspiration is not there anymore, so I'm way far away from the phrenic nerve. So I was able to ablate and bring the ablation catheter right here, and having this buffer of the fluid between me and the phrenic nerve. I didn't need to go and place a balloon and inflate it to try to say that phrenic nerve is going to be farther away. I was able just to do it end expiration and be able to keep it here and ablate it, that atrial tachycardia right from there, because I'm way farther away from the, and you can even see a stim pop. Look at, did you see that stim pop right there? That was a small stim pop. And that at stim pop, I'm doing slow motion, you can see. These stim pops happen so much more time that you can even imagine. They don't even cause pop. You don't even hear anything. The impedance many times doesn't even change. You just can see them on the ice. And if the ice is close to your ablation catheter. This is the last part I'm going to show you, which could be a nightmare in the EP lab, but you can fix it within a few seconds. This is my transeptal sheet. That's my ice is in the right atrium at this time. This is the air trapped inside the left atrium. So all of a sudden, my sheet didn't work well, and then I have a trapped air. So what am I going to do? No panicking. Just remove the circular mapping catheter from this sheet. So look at that. I'm just slow motioning to see that circular mapping catheter just came out. So what am I going to do? I'm going to advance that transeptal sheet towards the air. So you see the air right there. You see the transeptal sheet. Grab a 20 cc syringe and aspirate it. Let's take a look at it live as I'm aspirating it. And air is gone. Done. No more air inside the left atrium. So be proactive. Use your eyes. It's going to make your life much easier, really easier. And I think with that, I really thank you so much for your attention. I appreciate it.
Thank you very much for great examples. I enjoyed very much. I hope that everybody enjoyed. We are a little bit behind the time schedule, so you can ask Dr. Asminia during break, during lunch break or later. And it's my pleasure to invite another speaker who will talk about intracardiac echocardiography together with 3D mapping system. That's Fermin Garcia from Philadelphia. Looks like my screen.
That's my DEXA. All right. First, I want to thank Dr. Kausner, Peter, and everybody of my colleagues in Prague for having me again. And I'm not sure who chose this title. It was not me. I just given this, Intracardiac Echo and 3D Mapping, a perfect marriage. So the first thing I did before I started this talk is I Googled a perfect marriage. Because I just want to know how that looks like. And this is the #1 hit on Google. Is the perfect marriage somebody that killed his mistress and then his wife is the only hope? I don't know. But eyes and 3D mapping. And my role here is to continue the prior two talks because I think they were fantastic and I think this is probably one of the most important things in EP. But I'm going to combine somehow real-time imaging, which the only tool is fluoro and eyes, and our favorite tool, anatomically speaking, is eyes. And what would be the advantage of integrating this with a 3D mapping system? Because what's important to me on eyes and an EP procedure is that you can see the anatomy, but every patient is different. So whenever you're going to do these cases, you need to individualize the anatomy for that particular patient because not everybody is the same. And in your mind, it's the same, but it's not. Everyone here would have different eyes images if you were to explore that. And in order to do something in EP, you have to put a catheter in that anatomical structure. So eyes will help you go to that anatomical location. You always want to know who is your neighbor because that can help you for ablation, but that also can help you to prevent complications. So eyes will be very useful for that. Now, it doesn't matter what technology you use, and I haven't used PFA, but in my mind, there is no way you can do anything unless you're touching the tissue. So now you want to get that catheter to touch the tissue you want to ablate on the direct visualization if you want to have a lesion, because our role here is not to do beautiful maps of activation. Our role here is to ablate arrhythmias and cure the patient. The maps don't cure anyone. The ablation does. Now, it's very interesting. I'll talk to this briefly because eyes can be also very useful when combined with 3D mapping to define substrate, to define scar, and to look for things that you cannot see. And it could be equivalent as an MRI, except that now you're obtaining this information on the table. So I like to think, first talk, second talk, and my understanding is there has to be an anatomic arrhythmic correlation. And just in a way, what was done in the first talk, I will try. And this is by chance, because this is how I understand this. I'm going to show you some arrhythmias that have an anatomical correlation for that. because this is the only way you can design an ablation strategy. When you're on the table, when you have in your mind which is the anatomy, which is the arrhythmia, and how you're going to target this, because this, in my opinion, improve outcomes, but more importantly, or as important, it will decrease collateral damage. It will decrease complications. And this is the essence of this talk. So I'm going to put this example, just as an example. This is someone that comes from VT mapping, and I have reconstructed the ventricles. This is cartosound, the combination of the ultrasound with the 3D mapping. Now, one thing you haven't seen yet so far, it's all image, most image from the right side. Now, open your mind and start thinking that sometimes the closest you are to the structure of interest with less things in between you and what you want to image, i.e. less artifact, the best image. So you're going to start seeing things like this. In my opinion, to image the septum of the left ventricle, your best place to image is inside of the left ventricle, not inside of the right ventricle or the right atrium. So this is going to be an image. Now, this anatomy was recreated, this cartosound map was recreated with eyes in the right ventricle. You can clearly see here that once you put the eyes on the left side, you miss this whole portion because it happens to be that from the right ventricle, the septum, the ICD lead, something that's there doesn't let you see further. And once you reconstruct this with eyes in the left ventricle, now you have a full endocardial cavity. So the importance of this is that if you're going to map something, you need to know the anatomy. Otherwise, you're going to miss areas of interest. Now, I'm going to start with simple stuff, a left pulmonary vein. And actually very interesting that at the beginning of this start of the session, you were talking about eyes and PFA and how useful it's going to be. And I think it's going to be essential because this is eyes and RF. And I've been doing this for a long time. Now, every time I show you a nice picture, I'm going to go not as beautiful as the first talk because I don't have access to that. I'll go to the book and I find an image, macroscopic and microscopic anatomy of a left pulmonary vein. Now, in my mind, if I'm going to do the procedure, I want to find a nice picture that reproduces this. And is it possible? Well, you'll see. This is eyes, 3 different patients in the left atrium, okay? So here you can see a ridge, left pulmonary vein, posterior wall, and this is the esophagus. This is another patient, okay? And this is another patient. No single patient is the same. These 3 patients are 3 distinct patients with left pulmonary veins. Now, eyes is in the left atrium. You have beautiful picture of the ridge. You have beautiful picture of the vein. So how do you integrate that with the 3D mapping system? Well, what I like to do is I draw the anatomy, left atrium, left atrial appendage, pulmonary vein. Now, you can see your catheter, which I said before. You have the anatomy, you have the catheter, you have the location, you need the contact. Otherwise, you cannot burn. And this probably will apply for PFA. I'm not sure because I haven't done it. As I said, this is this catheter tip right here. So in this type of pictures, there's no question where you are. You know you're touching what you want to touch, and you can see that you need to get above 500 to get that white tissue that was described before. It doesn't happen unless you get there. This is a different example of a different patient with a totally different vein. You have to manipulate the catheter in a different way. So this is how you correlate in the left atrium your anatomy with the eyes. Now I'm going to take you to another example. This is mitral isthmus ablation. This is the anatomy. If you look macroscopically, and this is my personal diagram of this, you have the left ventricle, the insertion of the mitral valve, the left pulmonary vein. This is the mitral isthmus. So I divided in 3 areas, the proximal to the vein, the proximal to the valve. This area could have different length, different thickness, different shape. Could be concave, could be flat, could be linear, okay? Now, when you have the fat pad always around the AV groove, that's where you're going to have the vein and the artery. This applies for this, for LV summit, for everything, okay? And the vein of Marshall is a branch from the great cardiac vein that goes up. So when you inject vein of Marshall alcohol, you're affecting this portion of the isthmus. You're not affecting this portion of the isthmus. So if you think you inject alcohol and you're going to get full block on the line, that's not going to happen. because the alcohol goes posterior, like you saw on the picture they show you here on the anatomy before with the silicone. This is exactly the same. So this portion you have to ablate from inside and maybe from the great cardiac vein. Well, this is how it looks in real life, okay? This is your mitral valve. This is the left pulmonary vein, and this is the great cardiac vein. This is a long mitral isthmus and thick, and it's moving, and the patient is breathing, or you're under GA and you have control of respiration. But this is what you're fighting. You're not fighting the static map that is sitting there not moving. This is real life, okay? And this is an example of ablation, how you need to target this. This was alcohol injection. You clearly see the white tissue closer to the vein, but this whole area is untouched. So now you have to finish that with RF. And this is the anatomical correlation. And just to put, again, 3 different samples, 3 different patients, all different mitral isthmuses. So if, again, you believe that one fits all, not in the human heart, not in EP. Now, I'm going to transform this into integration with the 3D mapping system, because not only we're interested on getting an endpoint and curing the patient, but we don't want complications. This is reconstruction based on cartosound, eyes of the left atrium. These are the os of the left pulmonary vein. This is a lobe, the left atrial appendage. This is the mitral valve. This image, it's this image on eyes. So now you have the ability to display the eyes on your map. You can see with the thumb of the eyes what corresponds to this. This is the CS catheter. This is the CS catheter. This is the descending aorta. This is the mitral valve. This is the isthmus. Okay? This is the coronary artery. This is the great cardiac vein. This is another example of great variability. You can imagine how you can use certain technologies and ablate the endo and get coronary spasm, because you are 1 millimeter from the artery. And every patient is different in this fat pad. Now, you think of the esophagus always in the posterior wall. Well, look at this patient. I reconstruct the esophagus here, integrated into the mapping system. And the esophagus in this patient is lateral. It's not on the posterior wall. So if you were to ablate this, you have to be careful, because not every patient is the same. And the amount of energy that you're going to place here would be different if you don't have an esophagus sitting right here. Maybe this is a patient that you do some endo lesions, and because it's the proximal portion of the line, it would better serve with alcohol. But this is great anatomical variation, and the integration of this with the mapping system, in my opinion, becomes essential for a good procedure. This is similar to what was shown before, except eyes is again in the left atrium, and I'm simply going to clog from here to the posterior wall. This is in red, the ascending aorta, which, by the way, you can reconstruct. You can do partial thumb or map of something and then draw with cartosound, and you integrate both. So you exactly know the whole heart and chest anatomy. This is ascending aorta, pulmonary artery, reconstructed with intracardiac echo. This is the right superior pulmonary vein. This is the left atrium. So this is equivalent to this. So I look at McAlpin and I say, how I can reproduce this? Well, this is the aorta here. This is the SVC, which you're going to see in a minute. This is pulmonary artery right here. This is pulmonary veins. So what's in between? This is the roof. This is the roof. This would be transverse sinus, and this becomes what? Bachmann's bundle and the roof of the left atrium. So I'm simply going to clog from here and start turning, and you can see how this is the ascending aorta, the pulmonary artery, the roof, and you can see the simultaneous opening here. You can see now we have the right superior pulmonary vein, and as I clog more, the posterior wall, and then open the right inferior pulmonary vein. You see everything and you correlate. And I will adventure to invite you to look at right veins. These are all different right veins. So you think one size fits all? Never, never, ever. This is a right inferior pulmonary vein, posterior wall, right inferior, posterior wall. Now look at the posterior walls. Why do we have to create one recipe for ablation? This is a 1 millimeter posterior wall. This is 0.5 millimeter posterior wall. This is 0.5 centimeter posterior wall. All different. So it depends on where you're ablating. You can decide how much power you're going to use to affect that tissue, because all different orientation, all different location, and this is live. Now, I bring this slide and just put it in because I saw Dr. Rasminia's slide. And I further go and think, what happens when we make an atrium red? What happens when we isolate a left atrium because we think ablation more, it's better? Let's just burn the whole thing, right? Now we have very powerful tools that can do it in a second. Well, this is a patient that came for a redo procedure, and I went transeptal and I pushed the eyes in. Had extensive ablation of the posterior wall and a roof line. 6 months ago was on aspirin, Plavix, and a NOAC. Look at this. Are strokes coming from the left atrial appendage, or are we creating things in the left atrium that we never see unless we look enough? This is eyes in the left atrium in a patient who had 2 prior procedures and comes for a 3rd procedure. In this case, was epicardial flutter. I ablated it from the epicardium, but I wanted to map the left atrium. If I would have swiped multipolar catheter here, what would have happened? Now, I didn't have the ability to do what Dr. Rasmania did and aspirate all of this. I didn't want to mess with it. I just come out of there. I don't do anything. But we have to start questioning ourselves. Yeah, we have awesome new tools. Is this going to be the result of extensive ablation down the line? Can a patient ever be taken off anticoagulation? Now, this is another example. This is, again, McAlpine. This is the roof of the left atrium, the aorta, the left main. This is the equivalent to this. I have eyes here in the left atrium and looking down. This is the left coronary cause. This is the left main. So the only reason I'm saying this is whenever you think on these structures, think about your collateral structures, because like in this case, you're going to have the artery. Think about people who are isolating left atrial appendages. I've seen a couple of ST elevations in the LAD. They think it's vagal, this and that. No, you're next to the LAD. You have to be very careful, and this is very important for this. Now, this is a beautiful correlation that you will see, and I'll invite you to think about this. This is the back of the heart, as McAlpine described. Right ventricle gets the left atrium hooked to the mitral valve. The right ventricle hooks here, and then the right atrium hooks on top. And you're left with this, okay? This. This is how the posterior aspect of the heart looks like. The crux doesn't exist. It's just the anatomy that's called crux, because it's an epicardial space. But what's happening really in the atrium is that the plane of the mitral valve is higher than the plane of the tricuspid valve. And you are left with a step down, in which case, in the right atrium, it's right atrial tissue in front of the coronary sinus, but in the left ventricle, it's ventricular tissue. So what happens is you have a space that connects LV, and the opposite side is not RV, the opposite side is not epicardium, the opposite side is right atrium. This is how we went to this concept, okay? And think about it. Because of all of this, you have right atrial tissue opposite to this with no epicardial connection. Now I'm going to throw this out there. This is where you ablate AV and RT, right? This is where you ablate PSP PVCs. Could it be that they have something to do, one and another together? This is how we discover or observe how to ablate PVCs that came from here in the PSP region from the right atrium. We obtained this view, and we looked down, and we ablated PVCs from the right atrium. I always like to put fluoro because you guys in Europe don't have that much access to ice. You do have access to fluoro. So I want to show you how would a fluoro catheter look in this position, because I think that's how you're going to get value of understanding the technology of intracardiac echo. At least that's how I did it, because when I was trained, there was no ice, and people would tell me, oh, you are right there on fluoro, and I'm like, I don't know. I don't know what you're talking about. I cannot see it. So this is a patient that comes for AV and RT ablation, and this is the correlation of the lesions placed based on fluoro to the lesions placed in the mapping system and eyes. Okay? You're in front of the CS, you're below the HIS, so-called triangle of Koch. Well, look what you're really doing. You're ablating opposite to the PSP because the mitral valve inserts above the tricuspid valve, and you're left with a piece of tissue that sits right here. This is an AV-RT ablation guided by intracardiac echo. Now, this is a patient that calls for PVC ablation from the typical PSP area. Now you see ice here in the right ventricle, catheter is down in the posterior aspect of the LV, basal to the mitral valve. Here you have the catheter location of this. This fits to this. You can draw the His. You know you don't want to go up. You want to stay here. You want to have good contact force, and you ablate your PVC. That's early. Everybody's happy. Patient is ready to go home, and somehow we create a bunch of PACs, and the same patient has this. So this is the first of several cases that are plain observations, but I'm convinced of this. You can have patients with two diseases, or the same disease, two different arrhythmias. In the left ventricle, you get PSP PVCs. In the right atrium, you get AV NRT. You say, Fermin, you're crazy. Well, I'm going to show you the ablation lesions. This is RAO, combination of 3D mapping with carto, sound, and eyes. This is the His. This is the PSP lesions. This is the AV NRT lesions. They're right opposite to each other, because what you're doing is you are using this anatomical fact that I showed you at the beginning to have two different arrhythmias, and you end target them together. A His, it's always found. So I'm going to now show you a little bit of what happens here and how this is so easy. If you put a dot on eyes between the non-coronary cause, the right coronary cause, and the tricuspid valve. Now, some of my images are flipped because at Penn we're flipped. I try my best to flip it the other way, but just follow the anatomy, you're going to be fine. If I put a catheter here, you will always record a His. So simply, once you start your case, if you go to that anatomical spot in your 3D mapping and you put a tag, that's your His. You don't even need to find the His, because anatomically speaking, this is the membranous septum, and it's always going to be there. Now you can see the relationship. All this map was created with intracardiac echo. I didn't have to swipe a multipolar catheter for 10 minutes until the system recognizes to have an anatomy. I have the anatomy, I have the arrhythmia, and I know what I'm going to map. So here's an example of how to do this. This is eyes. I have tagged the His, and I recorded the His. Now, eyes again from the left side, okay? So I'm showing you eyes from the left side. If you see the aorta or the circle of the ascent of the LV outflow tract, you're close to the His. You never want to be there, because that's the left side of the membranous septum. Right here, you see, you have a His. See it? His. Correlation, EGM, His, location. Right-left junction, below the right-left junction, septum. This is from the left ventricle. Now you have a PVC, okay, that it's looking like this. It's a parahesian PVC. We map in the right side. We decided to go to the left side. And this is the earliest activation. Now this is the eyes, instead of on this segment, you can see the eyes here. I counter down and I go below the His. I see what? The mitral valve. If I see the mitral valve and my catheter stays stable there, meaning a vector of orientation towards the tissue and a contact force that stays constant, not moving, you're going to be able to successfully ablate the PVC and not cause heart block. And this is why I think this is so important to integrate the 3D mapping with eyes, because once you create this cut of eyes in the mapping system and you see your catheter, which by the way becomes green when you cut it, you know where you are and you know what you're doing. I think it's very, very, very helpful. I'm going to talk very briefly about this. This has been going on forever. You have image of a scar on intracardiac echo, and you do a voltage map, and then you correlate this with this. And that's how it looks. There are areas that are echogenic and that have thinning and have wall motion abnormality. This is how you define scar on echo. Same thing on intracardiac echo, because it's the same thing. So this is an example of a patient. We're doing a VT ablation. You can see a wide area that's mostly subepicardial. So we go and we do a map. Here you see again, this is the 3D mapping system. This line is the eyes cut, which corresponds to this. So right here, it's red in the area that is white on eyes. And when you do the VT, you see the mapping of the VT, and you see the lay potentials during sinus rhythm, corresponding to the area of substrate. So when we talk about a perfect marriage, this to me in EP represents the integration between a 3D mapping system, exact localization, EP, EGM information, and live, real, on-time location. And this is what ICE actually does for you. And it's very important to recognize that. I want to end here. And I think this is beautiful. This is new for me. We're working on the manuscript. And I'm not sure if anything but here has done this. But again, I start thinking, why do we fail? Why do I fail? Why do I have to tell a patient I couldn't do it? Then I go to the anatomy book, because it starts all there. We're failing because we don't understand the arrhythmia or we don't understand the anatomy. So this is my Kalpen representation of LV summit. And you already heard this from before. This is 2 different cuts. This is a more short axis. The limitation is that we're trying to ablate this tissue right here. Is the subepicardial surface of the highest point of the left ventricle. That's what LV summit is. The rest of it, it's not LV summit. We're trying to do this, and you try to do it from the endo, from the epi, from wherever. Now, this is a beautiful view. This is RVOT, PA. You saw this in the prior 2 lectures. Beautiful. In the first lecture, he shows a nice cut. Left atrial appendage. I say never go there to ablate PVCs, because it's not only that you're going to perforate the left atrial appendage, you're going to cook the LAD, cook it, because you're right on top of it, okay? So don't do it, okay? And understand the anatomy. What problem we have is that we're trying to burn this, but we're covered by the fat pad that contains the coronary arteries and the veins. So epi doesn't work. Don't even go epi for this. It's not going to work. You need to map, and you need to map inside. So when I look at this, I say, okay, what do we normally do? We do this. We map early, we pace map, great, and we go and we have a catheter here in the great cardiac vein, a catheter in the LV, here is laid. We're trying to sandwich this tissue in between. Well, that tissue in between is the left ventricle. And I want to show you fluoro, because it's not that fluoro is important, but if you're used to fluoro, to understand ICE, you have to see fluoro. And the usual way is we take a picture with coronary angiogram to say where the coronaries are. Well, I'm going to show you that this can be done with ICE. When I look at this picture and I ask Fermin, what we've been doing? Well, we've been imaging the LV summit from down here or from the right atrium. But we always foreshorten. We don't know the thickness, we don't know the location. So if I want to be short axis with my eyes pointing down, how about I place it on top of the LV summit, and that's the pulmonary artery. So if I place the eyes in the pulmonary artery, and now I look down, okay, so sorry, this is what I'm looking at. This is the PA, this is the LAD, this is the AIV, this is the LV endo, and this is the thickness. So I can tell you the thickness of the tissue between the endo and the epi. I can tell you how much fat that patient has around the AIV to know if I map from the AIV, I'm going to be successful or not. I can tell you the location if I'm going to do a bipolar lesion, which somebody here broke up as a question, exact location between the 2 catheters. And you can see here the left atrial appendage. Why would I even try to burn from the left atrial appendage to something that's coming from here? It's not going to work except cook the LAD. So this is a very nice view. Now, how do you integrate this with the mapping system? I'm going to show you right now. This is a case I did last week. You have here sound reconstruction of the cusp and the LV. And we are doing the first step on this approach, which I'm not going to go into detail. You target the anatomy opposite to there because you don't want to deal with the arteries, so you go to the LV endo. Well, here you have the catheter, LV endo, pulmonary valve, pulmonary artery, left atrial appendage. Again, this is reverse. I'm taking you through it. LV, you see the tip of the catheter right here. See how it gets green? That means the ice is cutting the tip of the catheter, so you know the location. You see an artery here and another structure here. Usually, God designed this. Even though there is variability, the veins are closer to the epicardial space than the arteries. Don't ask me why, but it's been anatomically known. So somehow they put this in our advantage. In the middle cardiac vein, in the AIV, everywhere you have a big vein, it's going to be closer to the epi than the artery. So you say, Fermin, how do you know that this is the vein and this is the artery? Well, the artery is more white, and you will see. So if I ablate from here, I have to penetrate more than 1 centimeter of tissue. And the heart is moving, and the patient is breathing, and even if I try my best for contact force, there is some abnormality that won't go. So then I decide I'm going to go opposite. Now I'm going to go and put the catheter inside of the vein. You can see now my catheter in the gray cardiac vein. This is so big, and I discussed this with Miguel many times. Alcohol doesn't work here because you are in the gray cardiac vein. You are not in a branch. The branch was late. I mapped the branch. It was late. You are earliest in the pure gray cardiac vein. So between the gray cardiac vein and the AIV, you can inject alcohol to big balloons. It might not work. So this is your best choice. Now look at this. This is the catheter, and you will see here the green marker. You see it coming? Right there, the green marker. So now I'm below the artery. This is the artery. This is the green marker. And this is the endo lesions. You see the white? This is my endo lesions. Didn't penetrate all the way here. So if I show you the fluoro, it's the fluoro I showed you before. I did angiogram. This confirmed that I'm below the artery. And this is a short axis view of this tissue. If you were going to do bipolar, this is very useful. And you can see here, cartosound, eyes constructed anatomy, correlation of the eyes and the map in the exact location, because you reconstructed it with eyes. You reconstructed by somebody moving a catheter, and then it looks distended, so I'm going to erase something here or something there. Now it looks better. Well, not that much. Take a little bit more from here. No, this is accurate. This is what it is. There's no question, because you did drawing of the endocardium. So it's perfection, integration with image when you do this. So to finalize, I think this is essential to design ablation strategies, I believe, that improve outcomes, and I believe that we can decrease collateral damage by creating an anatomic arrhythmia correlation for every patient. Thank you so much.
What you showed here, Fermin, was what I meant with perfect marriage. This is much better than you showed before at the beginning. Okay, I think we don't have time now for questions because we started later, so we keep questions during lunch break. And it's my pleasure to invite last speaker of this opening session, and it's Tom de Potter from Aalst in Belgium. And Tom will tell us about standardized workflows, how to improve efficiency and efficacy of catheter ablation. It's equally important as intracardiac echo. So those people who are leaving, they are missing point, because it's an important lecture.
Maybe just hungry.
Maybe you are hungry, or you need a biological break. I learned what is biological break. So it's euphemism for going.
How long do I have, Joseph?
15 minutes.
All right, 15. Let's do it. So thank you very much for the invitation. I think you need a bigger auditorium, Joseph. It's getting a problem. Hello, everybody. I would like to show you a little bit what we mean when we think about standardized workflows for PV isolation. Standardized workflows means how we work. It doesn't mean how you should work. I think the key concept is to standardize your workflow, not necessarily replicate one particular workflow. But the reason this is useful and important in PV isolation is, of course, because by and large, atrial fibrillation treatment is today still PV isolation is still the cornerstone of our treatment. And PV isolation, of course, unlike the beautiful mapping examples you just saw, PV isolation is probabilistic treatment. We don't need to map, we don't need to find where the extrasystole comes from, but we have other challenges. We need to solve the challenge of navigating and ablating in the complex 3D structure of the left atrium. And it's truly an example where technology has enabled treatment. Advances in technology such as 3D mapping, such as knowing where you put your lesions, such as knowing whether you delivered enough energy, and technologies to reduce radiation exposure have tremendously increased the efficacy of PV isolation. The efficacy of PV isolation can be improved on several levels. If you think about it, you can obviously intuitively start thinking about intra-procedural efficacy improvement, safety and efficacy enhancements through standardization, through some of the technology enhancements I've discussed, and some of them you will see throughout this workshop. But you can also think about what happens to the patient, of course, after the procedure, because if you want a highly efficient workflow, you need a workflow that you can count on, that you can depend on, and you need a workflow where you can be reasonably sure or very sure that you can discharge your patient in the same day, for example, and that he or she will not have complications. So rapid discharge is very important for that. And then finally, if you want to optimize your workflow in the lab, you need to think about what happens in your lab between cases. You need to start thinking about processes that are not necessarily specific to medicine, and actually I would argue it's very useful to get some help from experts outside of the field of medicine to enhance your resource optimization. I'll show you a few examples. So the first thing I think you need to do is figure out what you are doing, is understand what you are doing today and understand how is my workflow organized and where are the potential gains to be had. When we did this exercise, we sort of judged and discovered that our workflow mainly is divided in 4 phases. There is a setup phase of the procedure, and I'm not talking about installing the patient, but I'm talking about getting ready to do the ablation, which means accessing the left atrium. Then there is a map creation phase. Then there is a step where we do the actual treatment, of course, the ablation, where the main challenge, at least until recently, was to create contiguous point-by-point lesions. And then there is the validation phase, confirming that what you have done was actually successful. And when you further look at it, you can start understanding that this may or may not be different depending on your level of experience. Some of these steps and some of these procedural aspects will be highly trainable. Some of them will be very low variability from the beginning, for example, validation of PV isolation. But first, we start with the beginning, of course. We start with access, and in our lab, I think, and I don't think I need to convince anybody at this symposium, particularly not in this city, we believe that imaging is the key to everything. Imaging is the key to safety, and we believe in echo-guided everything. Echo-guided vascular access, of course, which means lower risk of vascular complications. You can argue that there is no randomized trial, and I will argue that there is no randomized trial to show that X-ray improves safety, but I think it is self-evident that echo-guided vascular access is the way to go. And I would argue the same for transeptal puncture. Echo-guided transeptal puncture, whether you do it with ICE or with transesophageal echo, virtually eliminates the risk of tamponade. You do, of course, need the equipment to do it. You need an ICE catheter, which can be expensive, or if you want to do TEE, you most likely need general anesthesia. TEE with sedation workflows is harder to accomplish. And general anesthesia in itself, I think, is something that is favorable for streamlined or standardized workflows because it allows more consistent workflows. It has the potential to provide better stability, better contact force in the ablation, and there may be, at least if we ask our patient, certainly a patient preference for general anesthesia. However, if you do GA, the conventional argument against GA is longer interprocedural times, longer peri-procedural changeover times, and this is solvable, and that is part of what I want to show you today. So here's an example of echo-guided access, and I think one of the key things to be efficient in your lab is to keep it as simple as possible. If you start complicating things, you will fail. So our echo-guided workflow is very simple. We identify the vein by pushing on the groin. I will show you one more time. No Doppler, no long axis, no I don't know what. To be honest, I don't even bother to put the probe in the correct orientation. Here it happens to be, but if it's inverted, it doesn't matter. The structure that collapses is the vein. The structure that doesn't collapse is the artery. You often see calcification, of course. And then you put the needle in the middle, below the probe where the vein is centered. You can see here on purpose I point to the artery to show you how you can identify it, and then you point to the vein and you puncture the vein. Simple as that. Same for the transesophageal echo for echo-guided puncture. This is an example of image integration. It's not something we do in our lab, but it's something that, if you are so inclined, is available to merge the TEE image with the fluoroscopy image, but TEE in itself does allow highly efficient and fast transeptal puncture, crucially without the need for any landmarks, without the need for any reference catheters, allowing very simple access strategies. We have a one sheet, one catheter access strategy, as I'm going to show you in a second. And so this approach, we have tried to build an approach starting from the access, as I just showed you, over the mapping to the ablation, to the validation, that is as homogeneous and as reproducible as possible, based on the ideas that Henry Ford invented more than 100 years ago to build cars, to do everything the same time over and over again, the conveyor belt. And when I tell my patients we will do the conveyor belt approach for them, typically they are a little bit set back and sometimes a little bit scared by the idea of going into a factory production process. But when you explain to the patient that a factory production process is exactly what you want for safety, because a production process where everything is the same every time allows you to identify variations of what should normally be the same and allows you to very quickly identify deviations from what is normal, they understand that this is a safety benefit. For the interest of time, I'm not going to specifically illustrate these aspects. They come back later anyway, but in our database, we've done over 5,000 cases with an approach where we obtain access, as I showed you, where we make a 3D model of the left atrium using rotation angio, where we import it into the 3D mapping system, and where we start ablating without additional mapping. Our ablation time for paroxysmal atrial fibrillation has dropped below 1 hour, clearly, with this approach. But the most important, the most useful aspect for efficient workflows is the standard variation of the procedural time, which is below 5 minutes, which means we can predict to a very high degree our procedural time and therefore maximize our lab capacity. This has evolved. This is an ongoing evolution. Here's an example of data we published 4 years ago, which means the data set that went into this publication is 6 or 7 years old, where you can see that we had a procedure time at that time of about 90 minutes with a standard deviation of procedure time of almost half an hour. This was at the time where we still used validation of entrance block, where we still used adenosine, and I will show you why we have abandoned this. Because the key factor to achieve standardization is eliminate variability. It doesn't really matter if your procedure is 40 or 50 or 80 minutes. What matters is that it is the same every time. And then you can determine how much time you have in the lab, and then you can determine how many cases you can and want to do. And as a side effect of standardization, you get some nice to have benefits, such as, for example, low procedure times and low X-ray times that come with the standardization. And as a desirable side effect, you get enhanced safety, because, as I mentioned, you can very quickly understand something is going wrong. 10 years ago or 20 years ago, I remember when I was a fellow, a PV isolation case in our lab, it took almost all day. And so if the case took long, maybe it was a bad day, maybe it was a difficult case, or maybe you were doing something spectacularly wrong and you didn't immediately realize. Now, this is different. Every case is the same. And if you deviate 2 minutes from the normal workflow, you know, and you start looking what's wrong and you fix it. And this is clearly a safety benefit. And as a second potential side effect, you may expect enhanced efficacy. Although this is not guaranteed, you can, of course, also argue, and you will observe, that if you strive for maximal efficacy, you may end up taking some shortcuts that you did not want to take. For example, very high power short duration ablation is a path that we have stepped back from again, because we observed that our first pass isolation rate has actually dropped a little bit with 90-watt workflows, and we went back to 50-watt workflows. Our workflow workflow today in Aalst is a setup phase. As I showed you, ultrasound-guided venous puncture, single transeptal puncture. We make a map by making a 3D angio of the left atrium and integrate it in the mapping system without additional mapping. And then we ablate. Still today, we rely a lot on point-by-point workflows. We use PFA, I'll show you at the end, but we still very much enjoy our point-by-point RF workflows that have proven efficacy and use published values for ablation index targets. And finally, validation phase. We have abandoned validating with a dedicated catheter and have started and published confirming entry block with the ablation catheter itself, thereby truly enabling and allowing a single access, single catheter workflow. And this we published last year. You can see that we managed to reduce our standard deviation procedure times, and we are reducing it further still because it should be and is for paroxysmal atrial fibrillation only, should be lower and should be achievable to get this below 5 minutes. This data set is, of course, all comers, it's not only paroxysmal atrial fibrillation. The workflow we use, as I said, is mainly still RF ablation driven. I expect this to change in the coming years, but in 2024 we are still enthusiastic users, and in our lab we are very enthusiastic users of the 50-watt Q-dot workflow. The 50-watt Q-dot workflow has as one of its ideas behind it a closed-loop control system that is not the normal temperature-controlled mode of the non-irrigated catheter, where you achieve a target temperature and the power is reduced. In the Q-dot system, the flow is modulated, so you can maximally try to keep your set power, and only if the increased flow rate is not able to control temperature, then the power will be reduced. So you can see this as an example here of the system. You can see that here you can see in blue the flow modulation, the flow going from 4 to 15 cc's per minute and back, and you can see in yellow that the power stays at 50 watts, that the power remains unchanged. So the idea behind this is, of course, based on the hope and the idea of creating better lesions, better suited to PV isolation in the left atrium. Hiroshi and his group published these preclinical data. I'm sure you've seen them, and if you look at it, there's a good argument to be made, I think, for the 50-watt workflow, especially if you are not intending to push very hard on your catheter. We certainly don't. I don't like doing 30-gram ablations. I'm more a 10-gram guy, I guess, and I think the lesions we get with the 50-watt workflow are ideally suited to this, and this is what we observe by looking at our first pass isolation rates as a proxy for lesion efficacy. And then endpoint validation, I told you we skipped endpoint validation, and at least we skipped adenosine validation. Why did we do this? Endpoint validation is useful if you think that there is a reasonable chance that your strategy failed. So if you know you put a perfect circle on the CARTO system and you know it will be perfect every time, there is no reason to test, of course. This is not true, certainly not. The first pass isolation rate and the lasting isolation rate is not 100%. But also a second thing needs to be true to do adenosine challenge validation. And this has to be that if you identify failure of your endpoint and you do something about it, that it impacts the outcome. And adenosine has been shown over and over again to fail number 2. Yes, adenosine identifies dormant conduction, but no identification of dormant conduction after adenosine challenge and additional ablation does not seem to improve clinical efficacy. So why do it? As a reminder, the mechanism of adenosine post-ablation, I'm not going to go in detail either, just to remind you that the mechanism of adenosine has been elucidated and understood, and some people still insist on using isoproterenol for dormant conduction, and isoproterenol does not exhibit this phenomenon that you see here. It does not work for dormant conduction, as has been said by somebody, I forgot who. The only value of isoproterenol in identification of dormant conduction is the time it takes to infuse the medication. And specifically for adenosine, a large group of Chinese investigators, together with Roderick Tong, randomized patients to 4 different post-ablation strategies where they looked at whether it impacted the outcome if you just do the isolation and go home, or if you wait, or if you give adenosine, or if you wait and give adenosine. And without, again, going into detail, the impact on clinical outcome was 0. It doesn't matter if you look for it, yes or no, so we stopped looking. And as I mentioned, we just checked for entry block with our ablation catheter. This is what we published last year. I show you some examples here. We use the microelectrodes on the Q-dot ablation catheter to check PV potentials before ablation. We can see the ongoing EGM reduction during ablation, and we can see post-ablation elimination of electrograms on the microelectrodes, specifically well suited, of course, to avoid far-field electrograms. We can also use the same microelectrodes in this example to identify residual conduction. Here is still an incomplete isolation, and of course we can additionally ablate that. We have shown this approach to be feasible and, of course, efficient in reducing procedure time. If you no longer do a double transeptal puncture and if you no longer validate with the lasso catheter, obviously you will get shorter procedure times, and we have shown this to be true with a preserved efficacy. So as a take-home for workflow, I think you should focus on what is needed. You should think outside of the box maybe a little bit if you can, and you can think about what you can do different in your lab. Do you need to do it? Do you need to check for dormant conduction? Do you need to do it now? Do you need to do it in this order or maybe later when something else is going on anyway? And I think one key takeaway is use ultrasound. Ultrasound is cheap, it's very easy to teach, it's extremely safe, and it's extremely efficient. And unlike highly advanced technological mapping systems, it never lies. The image is what it is. There are no image shifts or things like that. And then, if you allow me, Joseph, I have 4 or 5 more slides of examples of what you can achieve with optimized workflows. So, as I said, the first thing to do is to measure what you are doing. If you are looking to optimize your workflow, we try to record all our cases like this, understanding what happened when. What is the skin-to-skin time? What was the installation time in the lab? What was the preparation time? What was the actual procedure time? And what was the changeover time? And what was the cleaning time in the lab? And then we can do this for all types of procedure. It doesn't matter. And of course, the last example, AT after ablation for persistent AFib, is expected to last longer than paroxysmal atrial fibrillation. That's not a problem. What is important is, for example, that you can observe that you can have stable changeover times and that you can have stable workflows. This is our normal single-sheet workflow in detail, as I have explained in the presentation. So we have a single transeptal puncture. Through the single transeptal puncture, we make a rotation angio. From the rotation angio, we make a 3D model, and with the 3D model, we ablate typical skin-to-skin for paroxysmal atrial fibrillation, as you see in this slide, less than 1 hour, 50 minutes, give or take. With PFA, this is all rapidly changing, of course. This is an example of a standardized workflow that we use with one of the commercially available catheters. This is the J&J product, the circular integrated mapping catheter, where you give a preset of ablations, you rotate the catheter, you ablate, and you come more antral. The Farapulse device is a different geometry, but the idea behind it is very similar, of course, is to do a very standardized, very predefined way of approaching PV isolation. And of course, as you would imagine, with these approaches, you can go much faster. Still, here's an example of one such case we did with the circular mapping catheter, where you can see we achieve skin-to-skin procedure times of less than 1 hour. For the anesthetists, this means a lot. It means that because the procedures are shorter, typically the safety profile is enhanced. A longer procedure time is very clearly associated with increased patient risk if you use general anesthesia. And it means we can let go of a lot of the things that the anesthetists like for long procedures that increase risk. For example, arterial monitoring we don't do. We don't put Foley catheters in our patients, and we typically perform instantaneous access closure to get our patients home fast, especially if it's an afternoon case. For the morning cases, we can use figure of 8, of course, but for the afternoon cases, we can use vascular systems. There are 2 systems on the market useful for venous closure, the ProGlide system that you see here and the Vascade system. And we also published our experience with these systems enabling same-day discharge workflows within 6 hours from admission, not 6 hours from the start of the procedure, 6 hours from admission. And finally, to finish, as I mentioned at the beginning, if you want to increase your overall lab efficacy in a given day, and I'm not talking about one single procedure, but do more procedures on a day, I think you need to get help from optimization experts. We did that. This goes far too much in detail, but I want to show you that experts will bring ideas to you of concepts that you have probably never heard of unless you have a very particular interest in process optimization, where you analyze in detail every single thing you do in the lab. This is an example of what we did. We listed every single micro step of a procedure, and then we sat down and discussed how can we improve this. Because the goal of improvement is this. The goal of improvement, if you have ever seen an efficacy presentation, you have seen a Formula 1 pit stop. And the goal of the improvement is not the first part of the movie. The first part of the movie you are probably familiar with. You see a very nice pit stop, fantastic, 3 seconds. This is the cool part. The cool part is they can do it twice in a row. And I'm sure if there were competitions with 3 cars, they would figure out a way to do it 3 times in a row. And this is what you need to achieve with this optimization examples. You need to achieve, can we go to the next slide, please? Yes. You need to achieve this. You need to achieve, in blue, a stable inter-procedure time. It doesn't matter if your procedure differs. The first case, this is an example of a workshop we gave. The first case is AFib plus flutter, the second case as well. Of course, they last a bit longer than the simple paroxysmal, but the time between the procedures is exactly the same. In conclusion, today very high efficacy workflows are feasible. I would argue for standardized procedures such as PVI, they have become easy to implement. They are technology driven, and you need interaction with your friends and colleagues from other disciplines. And ideally, if you want to optimize your day, you need input from automation experts. We have seen in the past years the introduction of very fast, powerful, and potentially very safe ablation technologies. For example, high power short duration ablation, and of course, irreversible electroporation, which will radically change the field of ablation, AFib ablation, in the coming years. And in our lab, imaging has been the driver of innovation, 3D electroanatomical mapping, 3D angio, integration of fluoroscopy and the 3D mapping system, echo-guided anything, as I've shown you, to aim primarily to eliminate complications. If you eliminate complications to the maximum, you can increase your efficacy to the maximum. So thank you very much for listening, and I think we can have questions in lunch.